Our next presentation today will be by my GSAPP faculty colleague, Dr. Stephanie Lyon, who is an assistant professor of clinical practice at the Graduate School of Applied and Professional Psychology, working primarily in the ADHD and Child Behavioral Disorders Specialty Training Clinic, investigating mentalization-based treatment for children. Dr. Lyon earned her doctorate in clinical psychology from the Derner Institute of Advanced Psychological Services at Adelphi University and completed her pre-doctoral internship at NYU Bellevue Hospital Center. Prior to entering the field of psychology, Dr. Lyon taught elementary and middle school students and earned a master's in education from NYU. She is licensed as a clinical psychologist in New Jersey and New York and maintains a private practice in South Orange, New Jersey, where she treats children and adolescents, adults, couples, and families. Please join me in welcoming Dr. Stephanie Lyon.
Whoa, shaking the podium. Thank you, Christopher. Thank you, everybody. And thank you to our amazing keynote presenters. It was so wonderful. And I had no idea what you guys were presenting on before today, and I'm so excited that there seem to be a lot of thematic similarities between what you're presenting and what I'm presenting, so I'm really excited about that. Thank you for everyone for being here. A little apologies. I think we have a little like Mac PC formatting situation. So if some of my slides look a little wonky and some weird things are capitalized, it's because I made this on a Mac and then doing it on the PC. I was like, oh, some things look strange. So we're just gonna roll with it. All right. So as Christopher said, I'm Dr. Stephanie Lyon, and I'm here to talk a bit about the Cultivating Compassion project. I'm gonna start by introducing who we are. You all heard from Dr. Francine Conway earlier today. I think she had to jet off to another meeting. But Dr. Conway is the founding director of the Cultivating Compassion project. This is her baby, her passion project, back when she was the dean at GSAPP. And she hired me to come on as the director of the project 5 years ago. I think it's actually 5 years ago today, which is wild. Yeah. I have known Fran since we were both at Adelphi. She was my mentor there, so I was very excited to be able to continue that work with her here. So currently, Fran, despite being Chancellor Provost of Rutgers, New Brunswick, stays on as a didactic instructor and group supervisor for our project. I am the director and primary clinical supervisor. And then we have an amazing research assistant, or research manager, Dr. Sarah Alsady, who could not be here today because she is pregnant due several days ago. So she is here with us in spirit and awaiting parenthood. And we also have an amazing team of research assistants and training clinicians from Rutgers, undergrads, master students, and doctoral students, who this work would not be possible to do without. Okay, so I'm just gonna highlight a little bit of what we do. We're gonna dive into some of these things in more detail moving forward. So one of our primary missions is training graduate students in psychodynamic approaches to treating children and adolescents with ADHD and their families. That's a big part of the work that we do. We also have a project funded by the FAR Fund. We're hearing lots of FAR Fund props today here at RCAS, doing work on training the peer mentors in mentalization and how to use mentalization to support their mentees with autism. We have a quantitative research project that was a 3-year project looking at our ADHD treatment. That this is going to be the debut presentation of a teeny tiny little bit of that data because we just are wrapping up our 3-year data collection on that. And so I just began taking a look at some of the data. I have very, very preliminary numbers to share, which I'm excited about. And we also have a qualitative research project that's being run by Dr. Alsady. If anyone happens to be going to APA in August, we'll be presenting that work there. All right, so one of the main objectives of my presentation is to present neurodiversity through a psychodynamic lens. This is in contrast to both behavioral and neuropsychiatric perspectives that seem to dominate the conversation. I was really excited that the first presentation did not emphasize those perspectives, and so I think that these, the social justice lens that you guys presented through and this psychodynamic lens. I think they complement each other very well. This is not to say that behavioral and neuropsychiatric perspectives are invalid or inappropriate. From my perspective, at least, this is not an either or, it's more of a both and. And so to begin this discussion, we need to clarify a little bit of what we mean when we say psychodynamic, for those of you who are not super familiar with that term. Psychodynamic psychotherapy and psychodynamic theory is a modern, flexible iteration of the guiding principles of psychoanalysis that originated way back with Freud. Some of the core features of psychodynamic work are a belief in the unconscious, and that a lot of interesting stuff happens in the unconscious, such as some of the feelings, thoughts, wishes, motives that are harder for us to hold in our full conscious mind. So part of what we do in psychodynamic work is trying to uncover and understand some of the stuff that exists outside of our day-to-day conscious reality. There's also a focus on the therapeutic relationship as meaningful. You may have heard the terms transference and countertransference thrown around. There's an exploration of what is happening in the room between two people, whether it be a mentor and a mentee, a therapist and a client. And we also see the therapeutic relationship as a template of a working model of relationships and a place to explore what happens on the interpersonal field. Okay, so I'm just gonna touch a tiny bit on, we don't have time to go into this so much, but what some of the differences are between thinking about issues of neurodiversity and neurodivergence from a psychodynamic perspective versus sort of the mainstream medical perspective. So the sort of mainstream medical model Bible of diagnosis, you probably all know, is the DSM. Lesser known, there's a diagnostic manual that is centered on a psychodynamic and psychoanalytic perspective called the PDM, written by Rutgers' own Nancy McWilliams, that if you ever feel like reading a diagnostic manual for fun, I encourage you to take a look at the ways that these common categories of neurodivergence and neurodiversity are explained in the PDM and contrast that to the DSM. I have just a couple highlights of this here, but the differences are stark. So for example, as our keynote speakers identified, the DSM emphasizes deficits, it emphasizes genetic and neurobiological components, and it de-emphasizes context and individual difference. And the PDM, on the other hand, does emphasize the context, the interplay between the environment and interpersonal factors, and the many different etiological pathways to similar clinical profiles, that there's not A leads to B. It's like A, B, C, D, E, F, G can lead to something that looks like maybe X, maybe Y, maybe Z. And recognizing that there is immense diversity even within these diagnostic categories. So coming at this from a psychodynamic lens, we talk about what are the different ways that these conditions are often treated. And we have, I'm sure everybody here is familiar with the traditional treatments for ADHD and for autism. The traditional treatments for ADHD being stimulant medication, behavioral training, behavior management, social skills treatment, executive functioning coaching, etc. That's probably pretty familiar for most people. Yeah. Traditional autism treatment, things like ABA, skills groups, etc. There are some strengths to some of those approaches. They can successfully target and reduce and identify problematic behaviors and symptoms, or symptoms and behaviors that are deemed problematic. Sometimes the people deeming these things problematic are not the stakeholders themselves. But there are limits to what these treatments are able to do. They often fail to address the spider web of interactions, including the social dynamic, family systems, occupational difficulties. It focuses specifically on the individual and their symptoms, putting the onus and the context on them to be responsible for conforming to sort of a mainstream idea of how someone should be in the world. Often, these treatment gains with the traditional behavioral or stimulant medication treatments also do not generalize beyond the specific behaviors that are being targeted. And usually research shows us that there is a backslide or at least a lack of continued gains after treatment stops. For example, if you're treating someone with ADHD on stimulant medication and they stop taking their stimulant medication, gains don't continue. If you're treating somebody with a very strict behavior management plan, that can often work really well while you are rigidly employing the behavior management plan. But in a lot of cases, that doesn't translate into some sort of like internalized change. And then you stop doing the behavior plan with such attention to detail, and behaviors start to come back and behaviors start to backslide because we have addressed these things on a surface level. And that's not to say behaviors never generalize, it never results in long-term change, but research shows us that more often than not, these problematic behaviors begin to crop back up after treatment is discontinued. And we thought that that was only one piece of the puzzle, that people with neurodiverse conditions and neurodivergence deserve treatment that looks at the whole person and that looks at supporting optimal well-being in all domains, not just focusing on challenging behaviors and modifying behaviors. Just a little bit about the neurodiversity spectrum. I think you guys captured this so beautifully. When we're talking about neurodiversity, we're talking about a massive spectrum of different ways that people present in the world. And obviously, research really cannot agree on prevalence rates for any of these things because we have different ways of diagnosing, different ways of categorizing, underreporting in certain places. But these are just some typically agreed upon population estimates for various forms of neurodiversity and neurodivergence. So we have, if you take a look at those numbers, when it comes to autism spectrum disorder, ADHD, dyslexia, dysgraphia, dyscalculia, we have sensory processing disorders, we have numbers ranging up to 30% in some population-based samples of people who fall under these specific categories of neurodiversity, not even thinking about the overlapping identities within this neurodiverse spectrum. So we're talking about a great deal of people, which leads a lot of us doing this work to believe that when we look at this, that we are looking at this through too pathological of a lens. If we're talking about a way of being that affects up to 30% of people, and we're calling that pathology, we're pathologizing such a vast population of people that perhaps our way of looking at this as pathological is inherently flawed. So I want to bring up something that, again, the keynote speakers also touched on, was this myth of a normal brain, that if neurodiversity is this common, perhaps it is normal human diversity and not pathology. And when we treat it as pathology, perhaps we're doing harm to the people who we are trying to help. I think a nice analog here, at least from the psychology diagnostic position, is the way that historically LGBTQ identities have been pathologized. That it was not that long ago that LGBTQ identities were listed as pathology in the DSM, and the mindset has shifted over time to understanding those identities as a normal part of human diversity that is to be celebrated and supported. And I think we're not there yet when it comes to neurodivergent neurodiversity. But I think a similar shift is beginning to happen, where we're starting to see this as normal human diversity and thinking about ways that we can celebrate and support diversity of all sorts within people. And also, if we want to sort of try this game of categorizing people as neurodiverse, neurodivergent, or neurotypical, well, where do we draw the line? How do we know what is a normal brain? Are mental health conditions, depression, anxiety, are those neurodiverse? Are those neurodivergent? Are those on the spectrum of normal? I think we sort of have a long way to go in changing the way that we classify people as disordered or typical, and that the way that we treat people in clinical psychology needs to adapt as we're changing the way that we think about these things. Which brings us to the work that we're trying to do here. So we believe in neurodiversity as a natural variation, just like other forms of human diversity, racial, ethnic, gender, sexuality, etc. And if neurodiversity is just another form of human diversity, it deserves the compassionate respect with which we treat other forms of human diversity. That includes recognizing the impacts of social and societal oppression, looking at the level of systems rather than placing the blame on individuals for their lack of conformity to societal standards, and depathologizing the ways that neurodiversity manifests and challenges the status quo. So this compassionate lens on neurodiversity is at the core of the work that we do at the Compassion Project. So we believe that a lot of the difficulties that neurodiverse people face is a result of this culture neurodiversity mismatch, that the demands of the dominant culture are often at odds with how neurodivergent people exist in the world. And there's many different ways that that can be addressed. That can be addressed on the macro level by changing laws, public policies, cultural norms. That can be addressed on the community and institutional level by doing work like is being done at RCAS or at your project, looking at school climate, workplace accessibility. And then it can also be addressed on the interpersonal and the intrapersonal level. So the interpersonal level being family systems, social groups, the intrapersonal level being an individual's own insight, understanding, their ability to self-regulate and cope, their own confidence, how they see themselves in the world. It's these last two, the interpersonal and the intrapersonal, that are the focus of the work that we do at the Compassion Project. All right, so at the Compassion Project, we prioritize these 4 things. How am I doing on time? I'm talking pretty fast. Excellent. I had coffee today for the first time in 2 weeks. So I am like speedy. All right, beautiful. Okay, so we prioritize these 4 facets of our work, which is helping individuals understand their unique profile of strengths and challenges in a non-pathological lens. We work with families to best support their neurodiverse, neurodivergent loved ones. We work within systems, schools, social groups, etc., and we support mentalization. Before I talk about the 2 main projects that we are doing to put this into action, one with RCAS peer mentorship and then one with the ADHD clinic, I'm going to talk a little bit about the concept of mentalization. I know some of you were at a talk that I did here at RCAS a few months ago where we talked a little bit about mentalization. So some of this will be a review, but for those of you for whom this is new, feel free to jump in and ask any clarifying questions as I go, because sort of having a basic grasp on this will be important for moving forward. All right, so mentalization is a common thread in the work that we do. Mentalization first defined in the late 90s by Fonagy and Target, a psychological process that allows individuals to interpret their own and others' actions in meaningful ways. So pause and think about what that means for a second, that you're interpreting your own actions and the actions of others in meaningful ways. So right now, I'm looking out at the room, I'm looking at people's faces, I'm looking to see who looks puzzled, who looks engaged, who looks bored. I'm mentalizing you. I'm thinking about what might be going on inside you as you're sitting out there. And if you happen to be thinking about yourself and how are you presenting in this moment, you're mentalizing yourself. Or if you happen to be thinking about how one of your neighbors might be receiving this information or how I feel standing up here, you're mentalizing me. Mentalization is the capacity to understand your own reactions and those of others, and it's often in shorthand referred to as seeing others from the inside out, so thinking about what's going on inside you, and seeing yourself from the outside in. So how might others be seeing and interpreting you? So I'm going to give an example. So imagine that you walk into a room where there were 2 people prior to you enter. So maybe you're over there, you're walking into that workroom, there's 2 people in there, you walk in the door, they stop the conversation that they were having. You notice that one of them is red-faced and the other is crying. What might have been going on in that room? What was that? Sharing. Mm-hmm. Any other thoughts? Someone's getting fired? Something not great's happening in that room. Yeah, was there another idea? What feelings do you think those people might be having? You have no context other than that there was a conversation going on that stopped the second you entered the door. One person red-faced, one person crying. The red-faced person, what might they be feeling? Perhaps angry. Embarrassed. And the crying person? Grief, sadness. Perhaps anger. Do we know for sure what was happening in that room just by observing that moment? No, but we can take a best guess based on the cues that we have. That's mentalization. It's not mind reading. You're not like, oh, I know exactly what happened in that room. They were dating and that one just broke up with that one. Like, we don't know that. But we're using the clues based on what we observe to take a best guess about the inner world of those people. That's an example of mentalizing the other. You also can mentalize yourself. Another example. Imagine that you are a parent. I'm a parent, hence parenting example. And you catch yourself being extra testy and short-tempered with your kids one day. Even though they haven't done anything out of the ordinary, you're just a little bit on edge. And you recognize that. You take a moment, you recognize like, I'm being a little bit short-tempered today. You apologize to them and you say like, you know what? Sorry, I'm just being a little bit on edge today. I'm sorry about that. And then you take a step and you think back of like, well, what do you think's gone on today that's led me to be a little bit short-tempered? Did I not get a good night's sleep last night? Was work extra stressful today that I'm just like feeling a little bit on edge? That's an example of you mentalizing yourself. You take a moment, you see how you're acting in the world, you understand the behavior that you're demonstrating in the world, and you have a little bit of curiosity about what might be underlying that for you and how that might be received by the other people. That's an example of mentalizing the self. Any questions about sort of like the very, very basics of what mentalization means? Cool. So why do we focus on mentalization in the work that we do? Research has shown us that mentalization is important and linked to many other factors, including social functioning, academic functioning, relationships, empathy, and overall well-being. There's a lot of real-world implications to difficulties with mentalizing. And mentalizing is also something that comes more easily just by nature to some people than others. Some people are naturally excellent mentalizers, and some people, it's a skill that needs to be strengthened. And that's one of the reasons that we focus on it, on the work that we do. So to understand that a little bit more, we need to understand a little bit about how mentalization develops. Mentalization is a concept that's really closely linked to attachment, if any of you are familiar with attachment theory from psychology, in that it's rooted in the early child-caregiver relationship. Reciprocity between the child and the caregiver in the early relationship is the basis for understanding the link between ourselves and others. So when the baby cries and the mom looks at the baby or the caregiver looks at the baby with softness and care and empathy, that's a reciprocal interaction. And the baby begins to learn that, oh, I'm having an impact on this other person. This other person is responding to me in this certain way. And over time, interactions like that form the basis for one's understanding of their own emotions and their understanding of the reciprocity between themselves and others. And also it's the basis of their understanding of someone else's emotions. If that baby pulls mom's hair and mom looks stern, and then baby feels bad and starts to cry, that's a reciprocal interaction with a lot of layers of mentalizing. It's like, oh, my action caused distress in this person. I saw their distress by this stern look on the face. I felt bad about making that person distressed, and now I'm gonna cry. I feel sad. So you see there's back and forth mentalizing. There's mentalizing of the other party and mentalizing of the self. So optimal mentalizing develops with that sort of reciprocity. There's a lot of reasons that mentalization would not develop optimally. Sometimes there's just a temperament mismatch between an infant and their caregiver. For example, a very, very high need, loud, active baby with a more reserved, introverted, quiet parent, that parent is not going to be able to be optimally responsive and receptive and reflective towards that baby. Alternately, sometimes parents have their own mentalization difficulties. And if a parent has their own mentalization difficulties, they're going to have a hard time mentalizing their child, and then their child is going to have difficulties with mentalizing. Patterns of trauma and abuse in early life can also disrupt mentalizing. Prolonged separation or a child bouncing between caregivers, as often happens in the foster care system, that can disrupt mentalizing. Parental mental health difficulties. If you have a parent or a caregiver who is depressed or anxious, they may not be able to respond optimally to their child and might not lay the foundations for this optimal mentalizing. So we have sort of one way that things can work great and a whole host of ways that things can get kind of messed up along the way. So it's no surprise that we see mentalization difficulties cross-cutting through different sorts of difficulties that people can present with, everything from depression, anxiety, personality disorders, to a wide swath of neurodivergent presentations. So before we talk about mentalization problems, we're going to talk a little bit about what does successful mentalizing look like. I'm going to try to stop myself from using words like good mentalizing and bad mentalizing and focus more on successful and unsuccessful mentalizing. But if I slip into that sort of judgmental language, I apologize. Trying to untrain myself and continually to not pathologize. So features of successful mentalizing include a curiosity about the inner world of yourself and others. I'm sure you can think about people in your life who have what seems to be this innate curiosity about themselves, about relationships, about people that they interact with, and just how good it feels to interact with those people who are genuinely curious about you and seem curious about themselves and always eager to understand themselves. That's a feature of successful mentalizing. Just like in our example of walking in on the two people in the room, we're making best guesses about what another person is thinking and feeling. That's a feature of successful mentalizing. You can't be too sure, and you can't be too unsure. Those are both features of unsuccessful mentalizing. If you walked into the room and you're like, I know exactly what happened, not optimal. If you walk in and you're like, I have no idea what is going on in there, also not optimal mentalizing. But thinking like, I can sort of guess that maybe that person is angry and maybe that person is sad, but I recognize that I'm not totally sure. That's sort of that Goldilocks and the Three Bears, perfect warm porridge of mentalizing. The use of external cues to infer what someone else is thinking and feeling, and as I mentioned before, the awareness that you can't know for sure. Those are all features of successful mentalizing. Any questions? We all good? All right. So these are examples of what is not as successful mentalizing. What are the common difficulties people have with mentalizing? And we have three main categories of mentalizing difficulties. There are mentalizing breakdowns, hypermentalizing, and undermentalizing. Mentalizing breakdowns are things that we all, as mentalizing beings, experience from time to time. This is entirely normal to experience. And essentially what a mentalizing breakdown is when big feelings get in the way of understanding, get in the way of understanding yourself, or get in the way of understanding others. So who has not had the experience of being in an argument with a loved one and getting so upset that you can't be compassionate for them, or that you don't really know why you're doing the things you're doing? Your mentalizing has broken down at that point. When a parent, in being pushed to their limit of exhaustion and frustration and rage, hits their child, their mentalization has broken down. They are not able to hold that child's perspective in mind in that moment. They are not able to be compassionate. That doesn't mean that they can't at other times and that they don't at baseline love and care for their children, but their mentalization has been pushed to the point of breaking, and they have what's called a mentalizing breakdown, and they act in ways that are non-mentalizing. Two other forms of mentalizing problems, hypermentalizing and undermentalizing. Hypermentalizing is when someone feels overly certain that they know what's going on in the mind of another person. So if someone is waiting for someone to text them back and it's taking too long and they say, I know they hate me. I know I must have messed up really bad. They must hate me. Hypermentalizing. And undermentalizing is when someone cannot understand at all what someone is thinking or feeling or why they're doing what they're doing. It's when someone else's behavior in someone else's inner world is like a black box of mystery. And hypermentalizing and undermentalizing, just like mentalizing breakdowns, can happen to anybody, but we typically see that pattern more common in people whose mentalizing is underdeveloped or less developed. Anyone on the mentalizing spectrum can experience a mentalizing breakdown, though. Any questions on any of that? Yeah. Yes, absolutely. That's a really great question. And if you couldn't hear the question, it's, do the hyper and undermentalizing often go together? Yes. To get a little bit data nerdy on you for a second, the way that we measure mentalization, or one of the ways, is through a questionnaire called the Reflective Functioning Questionnaire. And when we have people fill out this questionnaire, it's sort of like on a pulled scale of like -2 to +2, where 0 is sort of the optimal balance of I feel sure, I am unsure. It's really often for the same individuals to have +2s and -2s, that they feel both certain and uncertain, but lack that sort of optimal best guess curiosity. So yes, you're absolutely right. Any other questions? Yeah. That's a really, really good question. And I do not have deep expertise in that besides to acknowledge that this research has been done cross-culturally and that these same patterns have been seen cross-culturally. Some of the researchers that are really deep into the reflective functioning / mentalization work have translated, say, mentalization scales into 50 plus languages and have administered it cross-culturally and see similar patterns. So that's a great question, though. All right, carrying on. So anyone can struggle with mentalization, as I've shown, and we all do at some point. But there's also well-documented patterns of mentalization struggles in neurodivergent people, specifically those with ADHD and autism. And it's also found in research that people with ADHD and autism also often have parents that struggled with mentalization. And we believe that for all people, but this work is focusing on neurodivergent people, that improved mentalization can lead to improved well-being and overall better functioning, particularly when it comes to how one feels about themselves and how one is functioning in social relationships. So now I'm going to talk a little bit about the specific work that we're doing. How am I on time? Okay, I think we're all right. Time is going quickly. So here at RCAS, we have partnered with the Peer Mentor Program, again, thanks to the FAR Fund. And we, in the past, I think we've been doing this for 3 years. We have trained, 3 years, I wrote it in my notes, more than 100 of the peer mentors at RCAS in the basics of mentalization and how to use mentalization in their work with their mentees. Obviously, the peer mentors are not therapists. They are not doing mentalization-based therapy, but we believe that infusing mentalization into the work in peer mentorship can support those relationships. So we have done this training for RCAS mentors, and we've also provided them mentalization consultants who are doctoral students who they can go to when they're trying to navigate a tricky situation with their mentees. And I have just a small case example, and this gets kind of tongue twistery, so bear with me. So this is a case where during a mentor-mentee meeting, a mentee brought up a conflict with their roommate. Specifically, this was a conflict around political ideology. And the mentee, who is a student with autism, was having a really, really hard time navigating this conflict. They went to their peer mentor listened and provided support, but felt stuck in helping with next steps. So the mentor consulted the mentalization consultant, grad student. This is where, see, I have this little graphic of concentric circles. You see that mentalization is like a Russian nesting doll, that everyone is mentalizing everybody in this like concentric circle fashion. The consultant, grad student, mentalized the mentor. Things like, it sounds like that was frustrating, like that you were trying to be helpful and you just couldn't figure out how to be helpful. The consultant also helped the mentor mentalize the mentee. This is the tongue twister part. So it's like, well, what do you think your mentee is feeling? What do you think your mentee is feeling? What gave you that sense? Trying to do that best guess, curious, looking at cues. It's like, oh, I think my mentee is in a lot of distress about this situation because of the way that they presented in this interaction. The mentor then mentalizes the mentee and their frustration. And then the sort of intervention is helping the mentee mentalize the self and the roommate. Like, what's going on during this conflict? Why are you having such a hard time taking this other person's perspective and holding compassion for them? What is that bringing up in you? And sort of talking through that exercise of understanding one's own emotional reactions, understanding what may or may not be going on in the mind of the other person, can allow someone to address that conflict in a more productive way, to move through it, to get out of that mentalizing breakdown that something as heated and passionate as a political disagreement could bring up. So to keep that person in a mentalizing mode. Our other main place where we're doing this work is in the ADHD clinic at Rutgers GSAPP. And in the 5 years that we've been doing that work, we've trained more than 20 Rutgers GSAPP students on mentalization-based therapy for children. And we've provided treatment for 50 plus youth with ADHD and their families using a psychodynamic mentalization-based framework. Also, originally funded by the FAR Fund. I'm not going to, in the interest of time, go too much into what mentalization-based treatment is, but I'll hit on the main points. So mentalization-based treatment was initially developed for adults, specifically adults with personality disorders, specifically borderline personality disorder, but has since been expanded as a treatment for lots of different presentations for adults and children, because as I mentioned before, mentalization difficulties are cross-cutting. So in mentalization-based treatment, we're always maintaining that curious, not knowing stance. We're making the implicit explicit, like, oh, it seems like maybe you're feeling this, and bringing this implicit thing to the external. Naming emotions, naming and describing what a child is doing to show that you're very attuned to them. You are curious about their way of seeing things. You're curious about their feelings. You're identifying triggers, you're identifying things that seem to cause mentalizing breakdowns, and you're offering empathy in the sport of mentalizing breakdowns. And then the explicit mentalizing interventions are things like linking mental states to behavior. Something like, oh, I see you fidgeting right now. I wonder if maybe you're feeling anxious. Or playing with perspective. If this is a play therapy, having people say like, oh, well, what do you think that character is feeling when your character just did that? And then mentalizing the relationship between the therapist and the child. So, oh, when you just flipped the game board over, I think you were feeling frustrated, and that also made me feel sad because I was enjoying playing with you. That's mentalization within the therapeutic relationship. So I have 2 case examples, but I think in the interest of time, I will just do one. Let's see. Which one do I want to do? Okay. So I'll talk about the case of S. I like this one because it's a play therapy example, and I feel like that's often a little bit more abstract to people than like a regular talk therapy example, which the other example was. So this is the case of S. She's a 9-year-old girl who has a 4-year-old sister and lives with 2 parents who presented to the ADHD clinic with a diagnosis of ADHD inattentive type and social anxiety with primary difficulties around carelessness and forgetfulness. And in mentalization-based treatment for children, we do this thing called the focus formulation, which is a guiding metaphor that is a strengths-based or neutral metaphor that describes the child and their unique pattern of strengths and difficulties that we share with the parents and ideally share with the school, so everyone has a common language that describes this child's unique profile. This one, we described S as a bubble. She's floating off in her own world. And the bubble can be a really beautiful place, but sometimes it's a little bit inaccessible. So the treatment was about how could the parents approach this bubble without popping it? And how could she learn to sort of exist in her bubble happily and peacefully? So the clinician's conceptualization was that S felt very different from her peers. She felt less than. She had very low self-esteem, which made initiating and maintaining focus particularly hard. That was one of her presenting symptoms. She had intact mentalization capacity, or her parents did, but hers was limited. She didn't have a lot of insight into herself and her emotions. The work with the parents in this case, done by one of our wonderful grad students, was about accepting their child's uniqueness. They had this vision of their child as this super independent, social butterfly, class president type. That wasn't ever who this kid was going to be. This just wasn't her. Well, that was weird. Did everyone see that? And supporting development of her mentalization by a curious stance, exploring her feelings, scaffolding her efforts to make links between her internal states and her external behaviors, rather than pathologizing her for just being herself. The child work involved a lot of psychoed around emotions, helping her identify what different emotions felt like in her body, what different behaviors she engaged in signaled that she was feeling different emotions. But the highlight of this treatment was this incredibly rich play therapy with the dollhouse. So very early on, there were two central characters in her play. There was this superstar class president girl, and there was this sad loner girl that no one liked. And it was so clear that that was the split between the self that she was and the self that her parents wanted her to be. And early on in this treatment, the class president, social butterfly girl, was getting all of the attention and all of the love and all of the praise from the other characters in this play therapy. And the therapist really would always try to bring some positive light, some neutral acceptance light to the other character in the play. And then over the span of treatment, which is 12 weeks, the other child, the one that represented her true self, began to have friends. She didn't become the class president. She didn't become the most popular. She did not become the social butterfly, but she found companionship. She had a little boyfriend. She had a little boyfriend that brought her chocolates in the play. And it just showed this internal shift over time of her believing that she was a pariah destined to be on the outside versus saying, well, I'm never going to be that. But I don't need to be that. I don't need to be the cheerleader class president. I can be my own unique self and still have relationships and still be accepted. And getting her parents to see that that was okay too, that they could let go of this vision they had of who their child could be and instead celebrate and help and support the child that they actually had. So that's sort of what this work looks like in practice. And in the last few minutes that I have, as I mentioned, we just started looking at some of this data, and I'm going to give our little sneak peek into some of the work that we've done. This is an analysis of just 10 completed cases from the ADHD clinic. It's 12 intake sessions plus 12 treatment sessions. And it's this mentalization, play, talk therapy, depending on the kid's developmental level. The older kids do more talking, the little kids do more playing. And in our treatment model, the parents get 1-for-1 sessions. So for every session the child has, the parent has a session that's designed to help the parent support their own mentalizing and their mentalizing of their child. There is practically no focus on reducing or managing ADHD symptoms specifically. We do not talk about managing symptoms. We do not give skills. We do not do any of that. We're really just sort of trying to see if we can holistically help this family and this child in terms of social functioning, relationships, self-esteem, etc. But because this was research and we were curious, we had the family's complete ADHD symptom inventories, because we were curious if this work that targets ADHD symptoms, not at all, has any impact on ADHD symptoms. And I'm happy to say that it does. So in just our analysis of 10 cases, doing a pre and post treatment Brown ADHD scale symptom inventory, we looked at, there's 3 scales within the Brown ADHD scales. There's an action scale, which is like hyperactivity. There's an inattentive scale, and then there's a combined scale. And in just looking at these 10 preliminary cases, we saw significant results in symptom decrease, both in inattention and combined. Hyperactivity, there's a trend there, but it's not reaching significance. But we did have significant results, which this is brand new as of last week. I was super excited and honestly, pleasantly surprised that not treating symptoms can have a positive impact on symptoms. Even a little bit more exciting, so this is a breakdown of the 10 cases that are included in that analysis, and the 2 that are highlighted at the bottom yellow are the ones that did not have a significant symptom change. But these are all of the different subscales within the Brown ADD scale outlined, and the higher the number, the more problematic that symptom is for this child. And in every single case, even the ones that did not have a net improvement, there was improvement on the worst symptoms. So whatever was that child's biggest problem, inattention in some of these cases, emotion in some of these cases, you can see I've highlighted for each column what the most problematic symptom was for that child. Every single one of those reduced. So that, even though some of these cases it didn't overall create much change, that feels good to know that whatever was the hardest thing that they were coming in for, there was some improvement in that domain. So what are we going to do with this work going forward? So clearly we're starting to look at this data and we're seeing that this treatment works really, really, really well for some kids and some families, and it doesn't work as great for other kids and other families. And we're trying to think about why that might be. Who does this treatment really benefit? And who is it maybe not ideal for? Because we understand that this isn't for everybody. So some of the things we're looking at, just based on our preliminary data and anecdotal evidence from our clinicians, is that maybe parents who are better mentalizers at baseline, this treatment works better for. Parents who have very, very unsuccessful mentalizing, I almost said bad, unsuccessful mentalizing, this treatment seems to be, so much of the treatment becomes about supporting the parent's ability to mentalize that it doesn't really have a chance yet then to translate into helping the child. So this is what we're starting to look at moving forward, is tailoring this treatment to support people in different ways depending on where they are at baseline when they come in. And we also have this really exciting qualitative project that's looking at the themes that emerge in mentalization-based treatment for ADHD. That's what we're going to be presenting at APA. So if anyone's there, I hope you come see us. And then I just want to leave you guys with a little takeaway to help you be your best mentalizing selves. So when you want to think about being an optimal mentalizer, here are some things to keep in mind. Self-reflection. When you find yourself acting in a particular way, ask yourself, why am I doing this? What am I feeling? Why am I feeling this way? A reminder to think about the inner world of others, what they might be feeling right now. How might they be interpreting me? Being curious about other people's feelings, asking them, what are you feeling right now? Or it seems like there's something on your mind. Showing empathy to others. And staying calm and practicing self-regulation during upsetting experiences so that you can minimize the likelihood that you will fall into a mentalizing breakdown and lose that really important capacity. And I only went a couple minutes over, and that's the end, and that's how you reach me if you want to. Thank you.